Good morning, everyone. Thank you for the opportunity to present in this symposium. I would say the success stories in iBank, the entire story of iBanking in India is a success story. As we stand today, we are the country second only to USA in the amount of corneas that are harvested and transplanted. And I see no reason why we cannot overtake that if everybody works in a concerted effort. I'll just give you a few snapshots of success stories from our own experience. We have the National Eye Bank at RP Center, AIMS. It is a government-funded eye bank. We have the director and the chief RP Center, and then we have a chairman, co-chairman, and an officer in charge. And of course, there's staff infrastructure and government funding. When you look at the numbers, they may seem small compared to some other institutions, but generally over the years, the iBank has gone from strength to strength, and it has been a cornerstone in training and teaching and providing human resources in the field. And consistently, we have maintained a utilization rate of more than 70%, and largely it is about 84 to 85%. And as Radhika, my co-name person over here, mentioned, we really need to think about making it 100% because there are eye banks who have 100% utilization, excluding only the corneas which have a definite contraindication like serology positive. So I'll just give you a few snapshots of some small success stories. Of course, you all know that the COVID pandemic led to many challenges, and apart from the first phase when everything completely stopped and then gradually everybody picked up, looking at Delhi where we had our Omicron wave in say December. So by the time we had picked up and started reaching our monthly collection of about a collection of 80 and say utilization of 70, then as the in December when the Omicron wave was starting, it was about still 83, 80, and then suddenly in January when the Omicron wave was fully in place, there was a marked decrease in the collection and utilization because there were a lot of patients who were under contraindication. Similarly, then in February, etc., it picked up and then went back to our total monthly collection of about 94 by March. So this is just an example of how we had these phases, and then we would like to appreciate the way the entire iBank staff and the entire infrastructure sort of adapted to the situation and move forward. Then we also noticed that we had an increase in our multi-organ donors. We had a very dynamic professor from the Department of Neurosurgery who's now posted in Trauma Center, and he personally was counseling the brain dead families. I mean, families of the brain dead patients in ICU. And you all know that there's a required request, legally required for ICU deaths. And he personally would counsel them, but he just told me that there were several multi-organ donors, like out of 8 in a year, there were 3 who had refused for eye donation when they had agreed for every other organ. So this was a little bit of a challenge, and when we spoke to the counselors and the coordinators, there was a lot of concern about disfigurement. Because all the other organs are within the body, and this is the one which is external, and they had to go long distances to the village, and they said in the village we have to go long distance, and they will say that you have led to disfigurement. And the neurosurgeon himself was not aware that there is no disfigurement. So he said, can you give me some pictures? I said, you can. He said, no, you give me some pictures because I personally talked to them and I spent several days of counseling. So you must give me some pictures. So I told the counselors that you only, whenever you take the, when you do the normal autopsy or the cadaver or post-mortem donations, you only take the picture because there's no point me giving an artificial picture. So you take the picture before and after. And then this we gave it to him in the small poster, and then he started using this for counseling, and then those refusals started reducing. And of course, we required, because you see, in a government setup, there is a changing population. You have residents, nurses, staff, and they all change from one department to the other, and you have to keep, there's a totally new team which comes, and each person has to continually be motivated. So we have to continue our motivation and promotion activities using cycle rallies and running, etc., involving the AIMS campus itself. And if you see, every year after the COVID pandemic, so the first year after the COVID pandemic, the annual figure was 750. In 2022, it was double that. Now focusing on the factor of non-utilization of corneas. So here again, we found that according to me, every HCRP cornea should be a utilizable cornea. And suddenly I found that a lot of HCRP corneas were actually being considered as non-optical grade. They were being used for therapeutic cases, but as far as I'm concerned, they should have all been optical grade. So I told them that and sometimes you'd have a young donor, say 30-year-old, 35-year-old, and the cornea was being graded as non-optical. So then I said, let's plug what's happening there. So there were some of them having long death recovery time, and the person grading would use that as a sort of a psychological criteria. So I said, no, there's no psychology involved. You have to consider that as an independent factor in determining the utilization, but you have to grade the cornea based on its anatomical and functional properties. So with that, we were able to, rechange and retrain the staff, and there's so many good people working, but I just like to highlight a few of the personnel. So we have this technician who would specifically take part in the cultural events organized by AIMS, so that he would develop a network with the entire technical staff. Similarly, we have this eye donation counselor. Earlier, we depended on external support organizations to support our eye donation counselors or grief counselors via projects. But over the years, there was a restriction on this because of the health ministry guidelines and also FCRA considerations, that the organizations were not able to meet the requirements and provide the funding. So we had created a post of patient care coordinators, which is a well accepted cadre in the government setup, and we were able to get our patient care counselor, our eye donation counselors incorporated under the cadre of patient care coordinators. And one of them, I'm just giving you one example, who has been very consistent in getting good quality corneas. And then of course we have a scientist and we have a nurse coordinator. And then also we found that a lot of these eye donation counselors were on their own saying that this is not suitable, not suitable, not suitable. And the technicians also were saying not suitable, because they were reading all the things from the NPCB guidelines, which is a guideline, but you have to take the consultation of the medical professional who is the doctor on duty. So we realized that they were wrongly, saying it's a contraindication, not even approaching the family. So we made it very simple. Who can donate? Anyone and everyone, except serology positive or hepatitis, known hepatitis, and active sepsis. And I said, you don't decide active sepsis based on the TLC report. You will consult the doctor concerned. That is an active sepsis. And then similarly, leukemia, lymphoma, eye tumors, and Alzheimer's, dementia, Parkinson's, and CGDs. This was just for the purpose of the counselors, so that they would have, and if they had any doubt, they would then consult the doctor on duty. And then of course we have the entire RPC family, which has always been supportive to the eye banking facilities that we have. So impact on keratoplasty, we started having pediatric donors, and here again the neurosurgeon sent me a message that we had this 4-year-old donor, can I know who were the recipients? And when I checked up, the recipients actually, they had been used in elderly people. One was a 30-year-old and one was a 50-year-old. So that was a bit unfortunate, because we have so many children waiting. It was just a question because the ecosystem was not geared to thinking that way. So therefore, we make sure that the recipient is of a child, a donor is a recipient is also a child. And sometimes it happens that with children it's challenging. Either they get URI on the day of the surgery or something like that. So we always have to have 5 to 10 children ready as a backup. So here are a few examples. Peter's anomaly, the donor here was, in this case was a 25-year-old. This was a 7-month-old and a 7-year-old recipient, a 7-month-old recipient, 7-year-old donor. Here we have a 3-year-old donor, 8-year-old recipient. So we try as far as possible. And we've had very good results. A 1.5-year-old child child with sclerocornea traditionally supposed to have very poor prognosis, but on careful follow-up, and then by showing these pictures to the counselors and also this neurosurgical team, we're now having many, many younger donors, as young as 1.5 year old. Now, we do know that less than 3 years old is generally considered as a contraindication, but if you have recipients who are the similar age group, so as I said, there's no blanket contraindication. Generally, we do take 3 to 75, but if you have recipients who are younger, you can. And then again, so this is one little girl who's had both eyes operated now, and we sort of had to, we still have a large number of patients waiting for keratoplasty. There's still 330 children, but it's not necessary that it's entirely because of lack of tissue. Sometimes the children also have raised intraocular pressure, and then they have repeated surgeries, and they may not be fit at the time of surgery. So patients with complete blindness also do have to wait. So this was that 4-year-old donor whose eyes were donated. They were transplanted in 2 adults who did very well, and but in future it sensitized us that we need to get the whole team in a very large organization where there are many people taking the decisions, and it's a question of allotting the cornea. It is also goes according to the waiting list, but you have to take other considerations. It's not simple mathematics. And so with that, I'll just want to say that these are the few small successes I'll say, but I wanted to share these experiences. Yeah, thank you.
Thank you, madam. Speechless. I don't know what to say.
All right.
I mean, all of us face the difficulties of availability of tissue, and many a times eye banks which we are associated with do get tissues, but then the quality is so poor that we cannot use it. So as you said, yes, we have to have ways of increasing the availability of tissues which can be utilized more.
One question about corneas which cannot be used, I think you should put them in glycerine. And honestly, this decellularization, we do not have to go to pig sources. We do not have to go to international sources. Within our country itself, we have decellularization protocols, and these corneas can be used for lamellar grafts. So we have one approved clinical trial now. We've done the animal studies where the human cornea, which is not suitable because that cornea can even be autoclaved when it's decellularized, just like vision graft. Now, vision graft, they don't share how they make it so transparent. That is something in the process which we are working on. But you see, these corneas, you decellularize them, and then you can use them for lamellar grafts. And growing the endothelium is difficult. So that is definitely a challenge.
Very true, and eagerly waiting for the outcome.
Yeah, hopefully. Then we will be able to use more corneas from everywhere. But please put them in glycerine. Because it's a very good option. And even for patch grafts, you can, because you feel good at least that the donor family who has given that donation, the cornea is used, it makes a difference. Yeah.
Ma'am, have you seen that the glycerin preserved corneas, which are white and thick, they clear over a period of time if it is used?
Yes. So with the glycerine preserved corneas, firstly, you cannot use it for a full graft. So you have to use it where at least there's some peripheral rim of corneal tissue. That's number one. So if you use it for lamellar graft, they can clear up. There are many publications from Brazil of DALC using glycerine preserved corneas. That's one. Secondly is when you're implanting them, wash them thoroughly, irrigate them nicely to get rid of all the glycerine, and they may not become transparent, but they can have a tectonic role. And the third thing is that like in tissues like DALC, if you properly select the case and don't go right up to the limbus, then gradually the glycerine preserved, because you see the stroma is fine. The only thing is there's no functioning endothelium. So they can clear up. There are many, but the only thing is we don't need to use glycerine preserve for DALC because we have a lot of non-optical tissue, fresh, which we can use for DALC. So from that point of view, I feel the glycerine preserved corneas, the main benefit is patch grafts and emergency surgeries. And then later, if our decellularization and all that, if we're able to show, then maybe you can use it.